Thank you for joining us for the Stanford Women's Health Lunch. I'm Andra Blumkals, Chair of the Department of Emergency Medicine here at Stanford. We are so happy you took this time to focus on your health and yourself. As women, we are often so busy caring for others. We put ourselves last when it comes to self-care. How many of you have put aside your health care screenings over the past 2 years, given up your own exercise routines, gotten tired of preparing healthy foods? In truth, I've done very little to care for myself during the pandemic. But what has become abundantly clear is that COVID will be part of our lives for some time. As you see today, all of our speakers are wearing masks when they're not presenting. They are all vaccinated and boosted. We will have to learn to live with the ebbs and flows of normalcy this virus brings and restore our self-care practices. Make that appointment for your mammogram. Schedule a colonoscopy or your routine blood work if you're overdue. Start exercising again, even if it's just a short walk or a few stretches. Genetics aside, so much of our own health is within our control. We can all mitigate our risk factors and optimize our health, no matter what our age. As an emergency physician, I see people with more advanced stages of disease this year after skipping routine healthcare screenings or struggling to maintain chronic conditions like diabetes, heart disease, obesity, health issues that sometimes could have even been avoided altogether. For the next hour, we will learn what we can do now, starting even this afternoon, this week, or in the coming months ahead to improve our health and help prevent the onset of chronic conditions. In our pre-event survey, we learned about the lifestyle changes many of you plan in 2022, from a plant-based diet to exercise, yoga, and mindfulness practices. These small behavior modifications are critical to your health and wellness. I am thrilled to welcome 4 of my Stanford colleagues here who will address women's health from head to toe. With just 60 minutes, we can't possibly cover every part of the body, so today we will be focusing on our feet, heart, bones, and brain. First, we will start with a part of our bodies that we often ignore. Most of us don't spend too much time worrying about our feet, but they are woefully neglected and often downright abused. Elizabeth Reilly, clinical assistant professor in the Department of Orthopedic Surgery, helps maintain patients who manage their foot issues almost every day. Thank you, Dr. Reilly, for joining us today.
Andra, thank you so much, and thank you to the organizers of this fantastic event focusing on women's health. It's going to sound really silly, but I'm very pleased to represent the toe in this series. Feet are unloved. They're just malaligned. I apologize. When we think of the foot, it does not get the love that it deserves. We believe in foot and ankle. That is the foundation of our body. It's what grounds us. It's what gets us where we need to go. Spoiler alert, many of my colleagues are going to tell you how important it is to get out and walk for a very certain time during the day. And then we need to take care of it. So like my clinic, I like to talk about anatomy first. We talk about the 26 bones, that's on each foot. We talk about the 30 joints, and then there's over 100 pieces of soft tissue. So when you do that math and you double it for the pair, it is really quite impressive. My best part of trivia is the 52 bones that make up the feet and ankle actually comprise the 25% of the entire bone structure of our human body. And even after 20 years, every time I say it, it amazes me. When I polled my colleagues about our discussion of feet and women's health, a pattern emerged. So what I decided today, if it's okay, is I would do sort of an old school top 5 list of the most important things that we'll see as your clinicians and sort of give us a little brief intro into each, and then we'll have some questions at the end. So coming in at a number 5 is onychomycosis, or as we'll call it, the dreaded nail fungus. I apologize, this is over lunch, but it's definitely something that has to be talked about and addressed. Nail fungus is the most common nail complaint of adults. It is an unsightly issue, I get that. There is aesthetics involved. It does get yellowed, crumpled, thickened. It becomes very difficult to maintain as the patient. But also it's a serious medical issue. It does predispose our patients to bacteria and skin infections. If we get what we call comorbidities, diabetes, vascular disease, it's definitely an issue. There are many over-the-counter treatments. As a rule, not a big fan. So what we prefer is you see a clinician, you get a little sample taken, really easy. We identify the fungal elements, and then we can have prescription strength topical or orals, depending on what's best for you as the patient. Coming in at number 4 is heel pain. Heel pain you'll see in male and female, it's pretty evenly divided, but the reason we'll bring it up, because if you've ever had it or you've had someone who has had it, it's awful. It's that first thing in the morning where someone's stabbing you in the bottom of the heel with a knife, gets better through the day, end of the day, you can barely walk. The classic diagnosis is called plantar fasciitis. Plantar means bottom of the foot, fascia is fat, and itis means inflammation. So we all have a plantar fascia. It goes all the way from our heels down to our toes, and it's called the windlass mechanism. What it is like a giant rubber band. So every step you take, this plantar fascia pulling, contracting. And so if we have too much arch, too little arch, the dreaded shoe gear talk, you go barefoot too often, this poor thing gets tired and overworked, and then it lets you know. If you do go to a clinician, you'll get x-rays done very commonly. You will see what we call a spur in the bottom. I would like to clarify, this will never be what hurts you when you have heel pain. Patients love to look at them. We love to talk about them. But if you and I are going to treat heel pain, we're going to talk about the itis, the inflammatory process. And so we have avoiding barefoot, shoe gear. We have anti-inflammatories. Don't be mad at me, but we have the dreaded steroid injection when it's appropriate. And then always, as the absolute last defense for heel pain, should be a surgical intervention. Coming in at number 3 is a Morton's neuroma. This might sound very specific, but talking to my audience, it's very specific for females. It's a pinched nerve in the ball of the foot. Now, when you describe it that way, it doesn't sound like much, but if you've had one, I've had one, they're excruciating. People will describe it as sort of a burning pain in the ball of the foot, walking on a bubble or crumpled sock. Good news, lots of conservative treatments. Don't be afraid to tell your doctor, because that is one we can definitely cure for you. Number 2, nobody's going to be shocked in this audience, will be bunions. Bunions happen to everybody, but they are a woman's issue. If you look at the literature, 10 to 1 female to male. It's that large bump that will get near the big toe. What I like to dispel is sort of the myths of bunions. It's not a bone tumor or a bone cyst. It's actually a malaligned bone. This, as women, will be our genetics, our structure, and then we have our talks like shoe gear and other issues. Don't be afraid to tell a doctor about bunions. There are choices, not as many as I'd like to offer, but we have choices. And then coming in at number 1 is shoe gear. If you've ever had a talk with women, it's always shoe gear. It's not the enemy people think it is. I describe it as sort of good, better, and best scenarios. Good is a nice heel, 1.5 to 2 inches, blocky, a little bit of an arch support. Better, flatter, 1 inch or less, really good arch support. And then best is ditch the heels and get yourself a really good pair of running shoes. I know nobody wants to hear that, but that is your best answer. Now, so I hope I didn't bum too many people out, but I will leave you on hopefully some good notes. Number 1, if you really say, what can I do, Elizabeth? Avoid barefoot. That's your best friend. Heel pain, arch pain, bunions, you name it, just put some shoes on. We were crazy busy during COVID because everybody was at home working barefoot. So please, please, please wear shoes indoors and out. I would tell you self-care, get a pedicure, love it. Just make sure you know where you go, you trust your stylist and your manicurist, and they have really good sanitary practices. But probably the most important things I would like to tell you is it is not normal to have foot pain. I do believe it has been normalized in women, and it isn't. It is not great to hurt. If it is hurting you, if it is a quality of life issue, do not be shy. Let us know. We are here to help.
Awesome. Thank you so much. I think we've seen everybody sort of move their feet a little bit when you were mentioning the type of shoes and things, and we'll just hide. It's all right. All right. Well, that's a wonderful reminder on an often sort of forgotten topic or forgotten medical problem. Yep. We have a few questions that our audience pre-submitted. So you mentioned bunions.
Yes.
What are the options other than surgery?
So limited, which again, I'm really sorry to tell you. So since bunions are truly a structural abnormal bony abnormality, I can't push it, inject it, therapy it back. So we talk about shoe gear, make it happy, make it comfy, bunion splints, toe shields, orthotics, don't underestimate their power. But don't be mad at us when none of that makes it go away.
Okay, all right. Another question. I have osteoarthritis of my big toe, which is slowly deforming my foot. What can you recommend to prevent further damage so I can continue to walk?
So if we'll think of the big toe as a tiny knee or a tiny hip, it is the same exact arthritis that you'll get, like the rest of my colleagues in Stanford Orthopedics would be very happy to help you with. But then think of it as a tiny knee that you're putting every single ounce of your weight on 10,000 steps a day. So it's that bone-on-bone joint arthritis that's just incredibly painful, limits your range of motion, limits your walking. Conservatively, it's orthotics. I know, they're not fun. Everyone, like, their eyes glaze over when I tell them. But for osteoarthritis of the big toe, there's something very specific called a Morton's extension. And it's like putting this very rigid beam underneath the big toe. You're still walking, running, do whatever you want if you have to, but it takes away that irregular range of motion into that joint, and it can be an incredibly useful tool. If you're very much anti-orthotics, which will bum me out, but I get it, you can actually talk to your provider and get a sort of a singular Morton's extension that I can get into better shoe gear as well for you.
Okay, okay. Is it possible to walk too much?
No, that's a hard no. And again, another spoiler alert, but I'm pretty sure every colleague on this panel is going to tell you the same thing. I need you to walk. From there's circulation, the nerves, right? Exercises the legs, the heart, the bone health. My goal is do it, but how can I do it happy, safe, comfortable? That's our job.
Blisters?
Friction, pressure, like better shoe gear.
Okay. I thought I found an excuse.
Darn it. Yeah, that's a hard no.
Okay. How can I relieve the pain of Morton's neuroma?
So Morton's neuroma, we chatted earlier, that is a little bit of a pinched nerve. Again, don't underestimate it, even though it's one of those, size doesn't matter. Even though it's this wee little nerve in the ball of the foot, it will bring you down quicker than anything. So again, that's the one thing. I do have a lot of great conservative measures, padding, shoe gear. If you can tolerate them, Hoka sneakers, because they have a very special thing called a rocker bottom that really alleviates the pain of a neuroma. And then there is, again, it's lunchtime, so I don't want to upset anybody, but we do have a series of injections called neurolysis. I did it to my own self, so I'm a big fan of, I know, it took me a while, but I got there, and it works like a charm. That's where we can deaden it with a series of injections with alcohol. And then there is a surgical intervention as well. The one pearl for me from Morton's neuroma is please do not get a steroid injection. That sort of used to be the standard of care, and we've learned we're actually not helping them. Literature tells us the success rate super lousy, and we've actually created some harm we didn't mean to. So if I left you with anything, no steroid injections for neuroma. Please have your practitioner or clinician talk about some other really great, easy conservative measures.
Awesome. Thank you so much for those tips.